the conduction abnormality here? I think for today's class we can finish ECGs and call it a day. Am I right? You still want theory questions, it may take a little longer time. Let's see. Now, what is the conduction abnormality? So it's a case of once more type 2 second degree heart block. Sudden drop of QRS complex without telling is there, which is an indicator of you see this P wave is there, no? Which P wave? This P wave is not followed by QRS, unlike the earlier P wave is followed by QRS. So that makes it a type 2 second degree heart block. Then what is the conduction abnormality here? So it is called WPW pre-excitation syndrome. So what do you have? How do you recognize? First of all, QRS complex is broad. And you are having a delta wave, an initial slurring of the upstroke of the ECG. Right? And if you look at the P wave and the QRS, this is the P wave, doctor, and this is the beginning of QRS. How is the PR interval? PR interval, this is T wave, don't worry on that. You see this, between P wave and QRS, the gap is very, very little. So short PR interval and wide QRS complex with the slurring of the upstroke of the QRS makes it WPW syndrome is what you have to remember. So for ventricular hypertrophy, what is the important criteria? If ECG says ventricular hypertrophy, there is ventricular hypertrophy. It has got a very high specificity but a low sensitivity. ECG is still not showing large QRS complexes does not mean the patient doesn't have ventricular hypertrophy. That's the point. In left atrial enlargement, what happens to the P wave? This is something that let us get a little straight and clear at this point, doctor. So in the anatomy2medicine.com video library, you have all ECG part 2, around 4 hours of video is there. So take a chance to review classical ECGs in exam, are already reviewed many times. So once more. You have, first set the board. First, catch. So you have seen Rudra Devi or not? I have seen, but going back into past, and that too very slow past. It is a movie that can be finished in actually 45 minutes. How she came up, how she was killed, how she killed others. Finished. Only 3 things. But it was like our cardiology class going very slowly and too long. So I thought that too 3-4 times I went out and came inside whether the things have come to a final stage of battle or not. So I was waiting. But it's a good attempt of trying to show the history. So doctors, we are talking about the P wave, left and right atrial enlargement. We have a lead V1. Speciality of lead V1 is what? It is placed on the right side. Then we have a lead 2. What is the speciality of lead 2? The axis of the lead 2 will be passing towards from right to left and up to down. If you take the left atrium, atrial activity is P wave. left atrial activity will be 2 atria are there. No, God has given. Left atrial activity will be passing, sorry, this is which side? Right atrium. Sorry. Right atrial activity is passing right atrium, left atrium. Down. And the left atrial activity will be passing towards left. So if you take P wave in the lead V1, right atrial activity will be on the right side, V1 is on right side. That's the reason it leads to a positive deflection, but left atrial activity is leaving the V1. That is the reason you get a negative activity. Overall P wave, how will it look like in lead V1? A biphasic P wave is the normal finding in lead V1. Okay? But if you take the lead 2 is going down and right atrial activity is also going down. So it is a positive deflection. Left atrial activity is going left and lead 2 also is going towards left. That's the reason that also will lead to positive deflection. And both of them will merge with each other. And what you get is a single P wave in case of lead 2. Whereas in the case of the lead V1, what do you get? Biphasic P1. Now, if the right atrial enlargement is there first, what is the effect of right atrial enlargement on the lead V1? Initial positive part is because of what? Right atrium. Negative part of this biphasic wave is due to left atrium. That's the reason if right atrial enlargement is there, what do you get? You get a significant positive initial upstroke with a normal negative downstroke, and this will be the change in of the morphology of the biphasic P wave in the lead V1. If there is a atrial enlargement, if there is a left atrial enlargement, initial positive remains the same, and what do you get? A significant negative deflection because of the left atrial activity. If there is a left atrial enlargement in V1, that is the story of what? Lead V1 mein how will right atrial enlargement, left atrial enlargement look like? Then if we take the lead 2, what do you get if there is a right atrial enlargement? If there is a right atrial enlargement in the lead 2, right atrial enlargement if it is there in the lead 2, then the right atrium produces a significant and a tall P wave, and left atrium also produces a P wave, but that become embedded in the right atrial's P wave. Left atrial's P wave become embedded in the right atrial P wave. So if there is a right atrial enlargement, then what will lead to will show a positive P only, but a significantly prominent high voltage P wave is what you see in lead 2. Okay. Then suppose if left atrium is enlarged, what will happen? P wave produces one P wave, and left atrial activity, because it got enlarged, earlier non-enlarged left atrium is producing a positive P wave which is hidden inside it. But because it got enlarged, it will produce a P wave which is no more hidden in this right atrial P wave, but separated away from that, so that the duration of the P wave increases and there is a notch which is developed. So you get a M-shaped P wave in the lead 2 if there is a left atrial enlargement. How many didn't understand? Come on. Pakka? Pakka? I don't believe. Come on. I am obsessive compulsive. आपका नाम क्या है डॉक्टर? हाँ? स्पेलिंग? MEH? मेहरी. राइट, चलो मेरी बेटे बैठो, मैं अभी एक क्वेश्चन पूछता हूं, आप फटाफट आंसर करो. अगर मेहरी आंसर करे तो पूरा भारत समझ गए एट्रियल एनलार्जमेंट. You are the sensitive investigation, diagnostic test for us. Okay? अगर मेहरी आंसर रॉन्ग करे तो पूरा भारत और एक बार सुनना पड़ेगा एनलार्जमेंट में क्या होता. चलो देखो बेटा, मेहरी ए क्विक रिकलेक्शन ऑफ द अर्लियर सीरियल का एपिसोड. Right atrium produced like this, left atrium produced like that, and V1 is a right sided one, but lead 2 is going down. सोच के बोलो, M pattern, if you find, it indicates which chamber enlargement. बढ़िया. Please give one big clap to Mary. Come on, come on. Dr. Mary, you want to be which specialist? Dermatologist. चमड़े की बात, फिर भी दिल की बात पहला समझने के बाद ही चमड़े की बात आएगा. हाँ चलो, लेफ्ट एट्रियल एनलार्जमेंट कौन सा लीड में बोलना. अरे कोई क्लू दे रहे पीछे से? नहीं दे रहे ना. हाँ, लीड 2. बढ़िया. Prominent P wave, sorry, prominent P wave is there. Which lead? Lead 2. Which enlargement? Right? Atrial enlargement. Badhiya? Then, initial slurring positive, same, but deflection, negative deflection is increased. Which chamber enlargement? Wait, stay. Left atrial enlargement. Which lead we are talking about? Lead V1. Then initial positive and the same negative means right atrial enlargement. And which lead? Big clap, big clap. So you are sure Dr. Mary is definitely, अगर ECG में right and left atrial enlargement बता सके तो bullous pemphigoid कौन है? Pemphigus vulgaris क्या है? Mucosal, oral mucosal involvement is a feature of which pemphigus vulgaris or bullous pemphigoid? We are vulgar through mouth because of a vulgar talking of the mouth. No, intraoral lesions where do you find? Pemphigus vulgaris. आप dermatology session नहीं attend किया? Attend नहीं किया? DNB का? अरे अगर आप आए तो हम बहुत एंजॉय किए थे लास्ट वेडनेसडे या मंडे. वेडनेसडे. तो खेलते खेलते हुए डर्मेटोलॉजी खत्म कर दिया. आप तो डर्मेटोलॉजिस्ट होने का ख्वाब है. हाउ कैन यू मिस? यू आस्क अवर पीपल. ऑनलाइन वीडियो लाइब्रेरी में है, रिव्यू करो. सो दैट इज द स्टोरी डॉक्टर. देन व्हेन यू आर इंटरप्रेटिंग एन ईसीजी, राइट वेंट्रिकुलर हाइपरट्रोफी, व्हाट कैन इट मिमिक? राइट वेंट्रिकुलर हाइपरट्रोफी, इफ इट इज देयर, V1 or V6, which lead is right sided? V1. So QRS complex become very prominent and a positive R wave will appear in lead V1 in right ventricular hypertrophy. Even in posterior wall MI also, you find a positive R wave in lead V1. अब बताओ, why do you get positive R wave in lead V1 in case of posterior wall MI? फटाफट बोलो, what is the cause? Typically this is the heart, doctor. You say V1 to V6, what are they basically? Anterior placed leads. We don't have a lead in the posterior aspect, right? So V1, V2, V3, V4, V5, V6 if you take. V5, V6 is called anterolateral. V3, V4 are called anteroseptal. V1, V2 are anterior fundamentally. So if you get a heart attack in the anterior aspect of the heart, how will it reflect? Before R wave, there is a negative wave which is basically called Q wave. Q wave. But if the posterior wall get MI, you can't see Q wave because there is no posterior lead. But what is the reciprocal of Q? Q is negative. What is the reciprocal of Q? Reciprocal is R. So instead of producing a negative Q wave in the lead V1, you find a positive R wave in the lead V1, which is a reciprocal change, which is similar to Q wave. In the posterior wall reflects as a R wave in the anterior wall lead. That's the reason if R wave is there in the anterior wall lead, normally will V1 contain R wave? R wave means positive wave V1 में रहता या V6 में रहता? V6 में, because heart activity is going towards left and V1 is after all what? Right sided one. So you don't find negative. You don't find positive R wave in V1. But if you find positive R wave in V1, what does it indicate? Posterior wall MI, or it can be because of right ventricular hypertrophy. That's the reason right ventricular hypertrophy is also called pseudo-infarct state, ECG wise, is what you have to basically remember. Now the correct diagnosis looking at the P wave here. P wave is became broad. So mitral, M-shaped broad P wave in the lead 2 is an indication of what? Left atrial enlargement. So what is the correct diagnosis in this given case? Classically it is a case of right atrial enlargement. How do you know right atrial enlargement? Lead 2 mein how is the P wave? Both tall P waves are there. Such a prominent P wave is an indication of what? Right atrial enlargement. And if you look at the axis, how is the QRS? It's a case of right atrial enlargement. Then what else? If you look at the lead V1, what do you find? In the lead V1, you are finding positive R wave, okay? And lead 1 and 3 you compare, 1 is drooping down, 3 is looking up, they are right towards each other. So because there is a right axis deviation with a positivity in the R wave, it is a right ventricular enlargement. Along with that you are also having prominent P wave in the lead 2, hence it is right atrial enlargement, a combination of right atrial and right ventricular enlargement, which you will see whenever there is a pulmonary hypertension. That's what you need to basically remember. But when do you call prominent P wave? That is also important. Normally P wave ka height dekhe to it won't be more than 2.5 boxes. More than 2.5 boxes if it is more taller, then you call tall P wave is what you have to basically remember. Then other than the first degree heart block, what abnormality do you see? Lead 2 में क्या है? बोलो बेटे, यहाँ क्या कैसे दिख रहे हैं? M shaped P wave. इसलिए वो उसको क्या बोलते हैं? P mitral is what you have to remember, which is seen in left atrial enlargement. What do you see in the ECG? Other than PVCs, what are you seeing? Typically you are finding QRS complex very, very tall in the V6. And what is the axis here? Lead 1 it is looking up, and lead 3 it is almost equiphasic, but overall looking down. So they left each other. So left axis deviation with a prominent R waves in the V6 makes it left ventricular hypertrophy. So what are the criteria to call Lyon-Sokolow criteria? Look at the lead V2 and look at its S wave. Look at the R wave in the lead V6. A R wave का height जो होता है V6 और V2 में S wave का डेप्थ जो होता है, अगर दोनों को ऐड करें तो if it is more than 35 mm, that is an indication of left ventricular hypertrophy is what need to be remembered. So what is the correct diagnosis of this ECG, doctor? Basically in this you are having right atrial enlargement, because in lead 2 P wave is very prominent, Huh? P wave is very prominent. And how is the lead one? Lead one is drooping down, QRS. Lead 3 is looking up. They are right towards each other. इसलिए इसको क्या बोलते हैं? Right axis deviation with right atrial enlargement. So what is the likely diagnosis of the ECG which you are seeing here? So it is once more. First of all, how is the axis? वो देखो. One ऊपर देख रहे और 3 relatively नीचे देख रहे, left axis deviation, और B2 का S wave and B6 का R wave दोनों को मिलाए तो more than 35 mm है. So इसलिए it is a case of left ventricular hypertrophy. Now what is the correct diagnosis in this given case? What is the type of axis बोलो? 1 ऊपर देख रहे, 3 नीचे देख रहे, इसलिए क्या हो गया वो? Left axis deviation है. और how is the V6 में R is very prominent and T wave got inverted. That's the reason left ventricular hypertrophy and inversion of T wave is called strain pattern, which is supported by your left axis deviation. To call it as LV hypertrophy is what need to be remembered. So think that you are a consultant of giving consultation of the ECG of a granny ma in a village who has come with an ECG on our telemedicine project. Fat diagnosis बोलना. Does she require echo or not? Is she the normal ECG or any rhythm disturbances are there? फटाफट बोलना. Hardly 10 things will be there. LVH, RVH, LAD, RAD, identifying atrial and ventricular arrhythmias, WPW patterns, fascicular blocks, bifascicular blocks. Then you are a rhythm specialist of cardiology, right, doctor? Then what helps to differentiate between a normal septal Q wave and pathological Q wave? Normal septal Q wave and pathological, पहला इसके बारे में एक दो बातें हो जाए. Normally, if you take the heart, how is the overall ventricular electrical activity is passing? From right towards left, it is passing. ठीक है? From right towards left, it is passing. क्यों? Ventricle, left ventricle is a big ventricle, hence it is इसको खींच रहे उसकी तरफ. Ventricular muscle. इसलिए V1 में आपको R wave आता या B6 में पॉजिटिव R wave आता? किस में आता? B6 में आता. So once electrical activity reaches AV node, it becomes divided into left and right bundles. And the left bundle electrical activity will go to interventricular septum. And it will pass from left towards the right. So पूरा ventricular activity के वजह से electrical activity mean axis is going towards where? Right towards left. But interventricular septal activity from left towards right. इसलिए what is the effect of it? All left sided leads. Interventricular septal activity is leaving it. From left towards right it is going. In all the left sided leads, before the R wave, you have a small Q wave which is a normal finding. So what are all the leads which are there on the left side? बताओ फटाफट. Lead 1 इसकी दिशा किस तरफ है? लेफ्ट की तरफ. So इसलिए lead 1 AVL उसकी दिशा किस तरफ है? If you connect the left arm with the left leg and take the right arm and compare it, you are having what is that lead called? AVL. So AVL also is ultimately going towards left side. So AVL is also called left sided lead. Then V5 V6 is also called left sided lead. ये चार लीडों में R के पहले क्या था? Q वेव होना नॉर्मल रिवर्स है, आप किसी के ECG में देखें तो। अगर किस लीड में R के पहले अगर Q आए तो एबनॉर्मल होता है राइट साइडेड लीड्स में। V1 देखो आप, अगर V1 या V2 में R वेव के पहले अगर कोई नेगेटिव Q वेव आए तो आने की जरूरत क्या है? Interventricular septum is coming from left to right. They should be happy. Why should they get that negative wave before R? Not required. If it comes, if a small Q wave comes before R in the V1, V2, it is considered to be absolutely abnormal. So what is abnormal? Finding Q before R in V1, V2 is abnormal. Finding Q before R in V5, V6, AVL and lead 1 is normal. Right? इसलिए Q wave in V5, V6 and lead 1 and AVL is called physiological Q wave. When do you call pathological Q wave? If the left ventricle suffers infarction, then you get pathological Q wave in the left sided leads. That Q wave will be more deeper, more wider than the normal Q wave that comes before R wave. In V5, V6 and lead 1 and AVL is what you have to basically remember. Now doctor, in acute MI, which ECG finding is first to appear? Hyperacute T waves, ST segment elevation, T wave inversion, appearance of Q waves, that is the order in which it progress. So what is the correct diagnosis here? So it is basically a case of, if you look at the 2-3 AVF, 2-3 AVF. What is 2-3 AVF are looking? Down, inferior wall, they are looking. So here you are having ST segment elevation only in 2-3 AVF. So that is the reason it is a case of inferior wall MI. Now what is the correct diagnosis of this condition, doctor? It is a case of lead V1 and V2, which are anterior leads. They are showing ST segment elevation. Are you able to see? T wave inversion. T wave inversion, ST segment elevation they are showing. Right? Even V3 and V4, they are also showing T wave inversion and presence of pathological Q wave. You see, V3 में इतना deep Q wave. Q means negative wave. And V4 also you find a deep Q wave before R wave. That indicates anterior and septal. Anteroseptal MI is what you will basically conclude. Just before we said no, Q wave, V5, V6, AVL and lead 1 में डीप है तो एबनॉर्मल है, मगर V1, V2 में अगर है तो भी एबनॉर्मल है. V3, V4 also prominent Q wave is indication of abnormal. Hence it is anteroseptal is what you need to remember. So what is the correct diagnosis in this ECG? Once more, here you have V2, V3 which is showing ST segment elevation. So that is the reason anterior and even lead 1 and AVL are also showing the presence of ST segment elevation. This is ST segment, this is ST segment elevation. Okay. So are you able to appreciate ST segment elevation here along with the Q wave? यहां आपको परिचय हुआ या नहीं हुआ? AVL में नहीं हुआ. I show you how it is looking like. I am once more showing you on the board. Q wave, then you are having like this elevation, ST segment elevation, and then the T wave is appearing. So Q wave and ST segment elevation and T wave is appearing. T wave also is inverted, should be inverted. Is it inverted? T wave to दिखाई नहीं दे रहे, flattening of T wave is there. Where? AVL में. But ST segment is elevated, Q wave is there before it, before R. So that's how it's an anterolateral wall MI. So what is the correct diagnosis in this case? So it's a case of 2, 3 AVF. Are they showing T wave inversion and ST segment elevation? A T wave, doctor, ST segment is elevated. Are you able to appreciate or not? Where is it like that? 2, 3 AVF. But V1 में क्या आ गया? R wave. V1 में R wave क्यों होना? नहीं होना. अगर है तो it's a reciprocal change of posterior wall MI. So इसलिए क्या क्या इन्वॉल्व हो गया? इंफीरियर वॉल इन्वॉल्व हो गया और पोस्टीरियर वॉल भी इन्वॉल्व हो गया. So what is the correct diagnosis in this ECG? Yeah? Typically what do you find? Lead 1 and AVL. Lead 1 and AVL is typically showing T wave inversion. Okay. So there's a reason it's called a high lateral wall MI. Is basically what you have seen. There was a correct diagnosis over here. We are finding one RSR pattern on V1. So it's a case of RBBB. Along with that, RSR in V1. Inferior wall 2, 3 AVF में आपको क्या दिखाई दे रहे? You are finding a Q wave no before R wave. So 2, 3 AVF is involved, showing Q wave, inferior wall, along with RSR in the lead V1. So RBBB. So inferior posterior MI with RBBB. Then what is the correct diagnosis over here? Here you are seeing the ST segment elevation involving V1, V2 and V3. So इसलिए it is a case of anterior wall MI acutely. Then what do you see in this ECG tracing? Typically you are finding V1, V2 are showing pathological Q waves. Q wave is, any Q wave in V1, V2 is pathological. On the top of it, it is very prominent. So what is the reason? V1, V2, V3, V4 is showing T wave inversion and Q wave. That's the reason anteroseptal MI is what you have to basically remember. Then which will cause ST segment depression? If you over breathe also, you will get ST segment depression. Lot of times politicians will be admitted, no? Politicians, they will get a chest pain. All TV channels will be seeing. You take ECG, ST segment depression will be there. You know how they will professionally produce that ST segment depression? You over breathe and then ask to take ECG. If you hyperventilate also, ST segment depression will come. Oh, politicians, सरपंच साहब को MI आ गया, ये न्यूज सुनते ही कि गवर्नमेंट चेंज्ड द पॉलिसी, देन इट इज देयर ऑन ऑल पेपर्स. एक आधे घंटे के बाद जाके देखो नॉर्मल ECG रहता, once his hyperventilation stops. So all ST segment depressions are not due to ischemia, be sure. Then what are the ST-T wave changes in the ECG which you are seeing here? So classically they are called as the normal form of ECG. I leave the literature for you. Right, doctor? I think most of the remaining questions are also on more or less same, showing ischemia in different areas. The whole idea is you should understand the various forms of ischemia. That is the whole idea. Okay. Now, doctor, yeah, we'll take something which is a little new, other than only ST segment changes. What is this condition you are seeing? Unbelievable. T wave merged with U wave to create a prominent wave, which is typically found in case of subarachnoid hemorrhage, is what you need to remember. So what is the best lead to see the normal U waves? V2, V3 is the best place. What is the abnormality you are seeing here? Basically QT interval, if you calculate, there is a long QT interval. Long QT interval. Once more, what is the meaning of QT interval? Beginning of Q or end of QRS? Beginning of Q to end of T or beginning of T? Come on, doctor. What is the normal QT interval? 40 milliseconds. Sorry, 400 milliseconds. 0.4 seconds. Otherwise, if it is more than 600 milliseconds, that is 0.6 seconds. If it is longer than that, then you call long QT. 400 milliseconds means how many chota boxes? 10. If it is longer than 10 small boxes, normally it is 10 small boxes beginning of the Q towards T. But if it is more than 600 milliseconds or 0.6 seconds, then you call long QT. Then the ECG shows LBBB. Why LBBB? William. Right? So RSR pattern is seen in the V6 and W pattern is seen in the V1, V2. Along with that, what else is it showing? It is showing primary ST wave abnormalities. So what is the meaning of primary ST wave abnormalities? If QRS can be either positive or negative. After QRS you are getting T wave. You look, how is the T wave, how is the QRS complex? Let's see. Let's see. You see the QRS complex. Where is the QRS complex that you can appreciate? Actually, primary and secondary ST wave abnormalities is too complex for the MD entrance exam, really not really required. That is DM level fundamentally. I mean, to go to such a micro level. So what is this QRS complex, doctor? One abnormal shaped QRS is found in this individual. What is that called? VPC, ventricular premature complex. That is 35-year-old non-alcoholic with 4 weeks of palpitations. What do you find? Sawtooth-like pattern. That is the reason. What is your diagnosis? Atrial fibrillation. So how do you want to treat? Give aspirin 100 milligram per day. And when do you call lone atrial fibrillation? Suppose if atrial fibrillation occurs in anybody who is younger than 65, with no hypertension, no cardiorespiratory distress, then such a type of atrial fibrillation is called lone atrial fibrillation, is what you have to basically remember. Then doctor, 61-year-old with history of ischemic heart disease since 2 years, chronic stable angina, and you have noticed something on the ECG. What did you notice on the ECG? Yeah, once more the bundle branches are continuing. I already told you how to identify bundle branch block. QRS complex duration is more than 0.12 seconds. Then what else you will find? RSR pattern will be found in V6. Right? Then one more thing will be there. Normally before QRS complex, what do you get? Before R wave, you get a small Q wave on the left sided leads. Just before we studied, left sided leads like V5, V6, before R wave, a small Q wave will be there. Right? If it is deep and wide, that is pathological Q wave. Suppose if that normal Q wave before R is absent, that is also abnormal. that is typically seen in left bundle branch block. Got my point? Why you don't want to ask? Sir, why Q wave before R wave become absent in left bundle branch block? You don't want to ask? From afternoon 2 o'clock you are breaking your heads now. No energy for asking. But I'll tell you. Normally in the V6 before R, why are you getting a negative Q wave? Why are you getting a negative Q wave before R in V6? First you tell me, just before we discuss it. Interventricular septal activity is going from left to right and leaving the V6, which is left sided lead. Hence V6 is showing due to that interventricular electrical activity a negative Q wave before R. But if the left bundle branch block is there, what will happen? Interventricular septum is no more stimulated from the left side. Now it got activated from right side. So that is the reason there is no electrical activity leaving. Hence Q wave also become absent, and what you get is a straight segment and then R. And that R will show RSR pattern. In case of left bundle branch block is what you have to basically remember. Left bundle branch block. Tirupati is saying, sir, please go slow. Doctor, if we go slow, we are preparing for the next DNB. DNB is conducted in May also. We discussed all these things in our ECG class, which is available in anatomytomedicine.com. It's only once more a story repeated. Right, doctor? But anyway, Saturday evening is a hip hop time. Reading too much is wasting a beautiful life. Already the disco jockeys are started their activity. So you still want to sit long and then listen the stupid discussion. But still, we'll finish some ECG part and then call it a day. 24-year-old man routinely investigated before employment, and you have looked at the ECG. So what is your diagnosis? Once more, RBBB pattern in marrow, RSR pattern in the lead V1 and W pattern in the V6, along with lead 1 is drooping down, lead 3 is looking up, they are right towards each other with a right axis deviation, hence it is a right bundle branch block. But always be careful, right bundle branch block may, don't forget to look at the axis. If the left axis deviation is there and the right bundle branch block pattern is there, then what is the diagnosis? RBBB with LAFB, left antero fascicular block, and that is the most common bifascicular block. Oh hey, masala in the story. So doctor, a routine ECG is being done in a 56-year-old presented with pleuritic chest pain. What is your diagnosis? Once more, it's a story of what? Left antero fascicular. What will left antero fascicular block will do for axis? What is the axis here? Lead 1, lead 3. How are they looking? Lead 1 up, lead 3 down. Hence, left axis, left axis. Then what else you are finding? What are the other features of the left antero fascicular block? So we discussed RS complexes in lead 2, 3 AVF. Where are RS complexes? Small r with a deep S. 2, 3 AVF में. Okay. Then tiny Q waves in the lead 1 and AVL. Lead 1 and where is AVL? AVL. Lead 1 and AVL में what do you find? Tiny Q waves is another criteria, and narrow QRS. How is the QRS? Is narrow. They are the 3 criteria based on which you will diagnose left anterior fascicular block. One important thing I want to tell you. What type of axis deviation is caused by left anterior fascicular block? फटाफट बोलो. Left anterior fascicular block has led to left axis deviation. But left posterior fascicular block will lead to right axis deviation. Please don't forget this. You ask me, sir, why left anterior fascicular block should cause left axis deviation? इसमें क्या कारण है? Very simple. Typically, if you take electrical activity, how is it passing? From right towards left, it is passing. Now, at the AV node, the fascicle is dividing into left anterior fascicle and left posterior fascicle. If the left anterior fascicle is blocked, how will electrical activity will pass? First it will pass through the left posterior fascicle, and all the areas which are on left side, earlier supplied by the left anterior fascicle, are now supplied by whom? Left posterior fascicle only. So left posterior fascicle finishes its activity and goes and supplies all the areas earlier supplied by left anterior fascicle. इसलिए entire electrical activity is getting directed towards left side. That is the reason what axis deviation you get? Left axis deviation you get. Suppose if it is left posterior fascicle block, then what will happen? All electrical activity of the left anterior fascicle is being supplied, and then electrical activity will go towards the left posterior fascicle supplied areas, because left posterior fascicle is blocked, and hence the entire electrical activity ultimately is getting deviated towards the right side. Playing, doctor, playing is ECG, right? 15-20 times if you keep seeing different types of ECG and use your brain to look at it. So summarize, doctor. LAFB lead to LAD, LPFB lead to RAD. But what is the most common combination? LAFB plus RBBB is the combination of bifascicular block. So general rule is what? Whenever left entire bundle got blocked, what type of axis deviation you should get? Left bundle branch block mein you get simple, doctor. Left bundle branch block lead to what? Left axis deviation. Right bundle branch block lead to right axis deviation. How will you remember it? Why left bundle branch block lead to left axis deviation? Abhi bolo. Now you will explain me. Left bundle got blocked. Then who will supply all the areas supplied earlier by the left bundle? Right bundle. So what will right bundle will do? First it will finish supplying all its right areas. Then it will be directed to supply the left areas. So entire electrical activity is directed towards left. That is the reason left bundle branch block lead to left axis deviation. By same analogy, right bundle branch block lead to right axis deviation. Left anterior fascicular block lead to left axis deviation. Left posterior fascicular block lead to right axis deviation. Oh, hai kissa. Huh? Without knowing all these things only, we got MD, second rank when I wrote the entrance. After that, oh, इतने bundles है, इतना axis है, इतना मामला है, बोल के समझ में आए. So that is the reason you should be good in common topics like hypertension, aortic aneurysm, valvular heart disease. They are the predominant topics. Where is mid diastolic murmur, early diastolic murmur, etc., etc. You must answer without mistake. Okay, on the top of it, ECG also you are able to make a correct answer. Good. At least electrolyte disturbances, VT, VF, atrial fibrillation. Okay. Then MIs, different types of combinations of MIs, and RBBB, LBBB. Too much. Examiner will be very happy. Kush ho jayega. So that is the story, doctor. Then a 66-year-old along with a history of hypertension and diabetes. Yeah. She is being investigated for a prior cholecystectomy. So what is your answer? RSR pattern in lead V1, hence it is right bundle branch block. But what is the axis here? Lead 1 going up, lead 2 going down. So that means left axis deviation is there. Why should it be there? It should not be there if there is a right bundle branch block. If it is there, what does it mean? Bifascicular block. That is RBBP plus LAFB. Finish, Katam. Then one of your colleagues from gynecology department is consulting about this funny looking ECG. What is funny about it? It's a 3rd degree AV block. That means P waves are not preceded by QRS complex. QRS is not always preceded by P waves. It looks like P waves are marching across the QRS, and hence it is an example of 3rd degree AV block. 18-year-old with abnormal looking ECG as a part of the routine investigation. What do you find? First of all, distances dekho. Suddenly there is an increased distance here, there is a shortened distance. So what do you like to call this as? Suddenly in the middle, QRS is being dropped. And there is a reason it is a case of type 1 2nd degree heart block. More or less the ECGs are same what we discussed earlier, doctor. Yeah.